Dr. Barnett is principal of optometrist at UC Davis Eye Care Center in Sacramento. She's internationally recognized as a key opinion leader. She specializes in anterior segment disease and dry eye. She is a fellow of the American Academy of Optometry. She's a diplomat of the American Board of Certification in Medical Optometry. She serves on the board of the American Optometric Association. She speaks extensively for the GPLI, which is the Gasperm Lens Institute, their educational branch. And then she's also the president of the Scleral Lens Education Society. Her attributes and distinguished honors that she has received, we can go on, but at this point I am going to turn it over to Dr. Melissa Barnett and allow you to understand what she has to present to you today for the scleral lens surface treatment and troubleshooting. Dr. Barnett?
Well, thank you so much for the kind introduction, and thank you all for attending today. I really appreciate you taking time out of your busy schedules. So this talk is going to be a little fun. It's a little different. I do work with several companies. Here you can see the disclosures. But we have patients, and I have patients every day that come in and they say, these lenses are great, my vision's great, when I first put them on everything's fine, but then throughout the day my vision gets blurry, the lenses aren't as comfortable, I need to take them out, put them back in, and here you can see in the picture all the debris on the front surface of the lens. So I actually had this patient yesterday in my chair, this exact patient who said, you know, that just this, you know, my vision's great right when I put them in, but it gets foggy or hazy during the day. A lot of my patients also describe this as oily, or if I ask them, is it oily like oil on water, what you're describing, then they say, oh yes, that is. And I do like to differentiate it from corneal edema that may also occur with scleral lenses. So for those patients, it's more hazy, rainbows around lights, shower glass sort of appearance, just to differentiate the different symptoms. But poor surface wettability really increases chair time, so these patients are more time intensive, which of course increase costs to both the practitioner and also to the patient. There are many different patients who are at risk, and the most common ones are those with ocular surface disease. And we see ocular surface disease in kids and adults. This includes meibomian gland dysfunction, blepharitis, Demodex, dry eye. And here we're looking for not only corneal staining with fluorescein. I really like using lissamine green and looking at the conjunctiva, looking for staining on the conjunctiva prior to the cornea. Now, our patients at risk for front surface debris, those with exposure, for example, if they have lag of thalamus, which could either be chronic or a new sort of symptom, those who have ocular rosacea. And I find ocular rosacea is pretty common in my patients. So when I'm examining their eyelids, I can see their blood vessels that are wavy right there at their eyelids, and then I'm looking at their face as well to see if they have any facial signs of rosacea. I find that just, you know, looking at the eyes, looking at the face, I'm picking up rosacea much more often, I would say, these days, and patients are being treated. So my patients are actually thanking me for finding the facial signs of rosacea too, which can be treated, of course, and there are certain products and medications that help, and cosmetically it also looks quite nice. So patients with severe dry eye like Sjogren's syndrome, autoimmune disease like rheumatoid arthritis, lupus, these patients may present with filaments on their cornea. And these are also the patients I see in my clinic. I do have a special interest in Sjogren's syndrome. And these patients can be really symptomatic. Their eyes are painful every time they blink. It's just really bothersome and affecting their quality of life. So I did have a Sjogren's patient in on Monday, actually, and I love using scleral lenses for these patients because they have the immediate relief. And I put the lenses on, my eyes feel so much better. They feel great. And she also mentioned she could open her eyes more immediately. So these patients are very satisfying to fit. And now that we have multifocal scleral lenses, it's really fun to play around with those too. So getting back to the ocular surface, lipids in the tear film can also deposit onto the lens and create a foggy and hydrophobic surface. So here you can see examples of exposure. So for example, someone who had a stroke or a new nerve palsy, their eyelids cannot close all the way. Of course, it could be one eye or two eyes. Someone who had any sort of eyelid repair, whether they had a blepharoplasty or they had ptosis repair with excessive exposure, this also affects the front surface of lenses. And this is quite true in my patient population as well. Makeups can definitely get onto the surface of the lens. Many of my patients are concerned who wear scleral lenses. Oh no, I won't be able to wear makeup. And I said, no problem. You just put on your lenses first and then apply your makeup, and that goes to moisturizers as well. So facial moisturizers, any creams on the skin or around the eyes are applied after the lens, and makeup as well. And I like to ask my patients what specific products they're using and making sure that they're applying them after their lenses are inserted. Plungers and having clean and new plungers also quite important, and we'll get to that in a little bit. So all gas-permeable lenses start out hydrophobic. Here you can see the first generation of gas-permeable lenses, silicone acrylate. And at this time, the material offered some distinct advantages to its predecessors like PMMA. So silicone acrylate was not only a better thermal conductor than PMMA, but it also had less lens warpage. However, some disadvantages were decreased optical quality, decreased wettability, and greater protein deposition. Silicone is great or not so great, depending on your opinion, but silicone is really helpful for oxygen permeability. So the hydrophobic nature attracts hydrophobic substances, but any exposed silicone creates non-wetting areas. More silicone is not necessarily better because it can cause poor surface wettability. More proteins can deposit onto the lens. The lenses can flex more and become less durable as well. So the incorporation of fluorine was used to overcome many of the shortcomings, which brings us to the second generation of gas-permeable lenses. So the fluorosilicone acrylate lenses, when fluorine was incorporated, the polymers combined the silicone acrylate material with fluorinated monomers. So this helped improve oxygen permeability, helped with wetting, less protein deposits. However, there are greater lipid deposits, and these lenses, of course, are more sensitive to harsh cleaning agents. So here you can look at oxygen transmissibility, and this allowed for the reduction in the siloxane component, giving the material a better wetting characteristics. However, the material was also more susceptible to lipid deposits. So surface wettability, otherwise known as the wetting angle or contact angle, describes how a liquid spreads across the surface. And I really like pictures, and here you can visualize the pictures. So on the left at the bottom, you can see there's no wetting. The contact angle is 180 degrees. The picture right next to it demonstrated poor wetting with a contact angle more than 90 degrees. The next image shows good wetting with a contact angle less than 90 degrees, and the picture on the far right demonstrates perfect wetting with a contact angle of 0 degrees. So the wetting angle or contact angle is the angle formed when a drop of liquid is placed on the surface, and it defines the ability of the moisture to spread. So now we're moving on to plasma treatment. So plasma treatment is a very effective cleaning method to remove any remaining residues on the lens from the lens manufacturing process, especially organic lipids. Now, I love plasma treatment. It's really almost the standard of care. I am very upset, my patients are as well, when I order lenses plasma treated and they're not. But plasma treatment is really helpful to have that sort of initial comfort. The lens is wet better. The plasma treatment is used to effectively remove the residue from the manufacturing process, and it's been wonderful for many years. So plasma treatment has been shown to reduce the wetting angle to less than 20 degrees. It creates a more hydrophilic lens surface, and this discussion was even this last month that plasma treatment is not a lens coating. It's like a super duper surface cleaning. So here you can see the image at the bottom demonstrating the wetting angle before and after plasma treatment. So it's definitely very helpful, and it makes the lenses as clean as they will ever be. When lenses are plasma treated and put on a patient's eyes, they're more wettable initially, and then the body's tears and natural biofilm coating process takes over. So it's a very effective process. So here you can see the lenses that are plasma treated are placed in the lens tray and placed into the plasma chamber. Air in is taken out of the chamber, and high energy oxygen plasma fills the chamber, cleaning and oxidizing the lenses. So here's the super clean lens. The lens is immediately placed in solution, and it is important for the lens to be wet and not dry. The process takes about 11 minutes. The bulk of the material itself is unchanged, but the lens surface properties are changed. So it's very important to keep the lenses moist. If the lenses become dry, then they become statically charged, and we don't want this at all. So keeping them moist, dispensing them as soon as possible after receiving them from the lab. And plasma treatment may wear off over time, but it is very helpful, and I really have enjoyed using plasma treatment for my lenses. It is important not to use abrasive cleaners for plasma-treated lenses, so using solvent cleaners like Optimum Extra Strength Cleaner or Low Bob Cleaner and alcohol-based cleaners like Sarin Cleaner are really helpful. So an abrasive cleaner, an example of what we would not want to use is Boston Advanced Daily Cleaner. So it's important to educate our patients to not handle the lenses more than needed, not to use the abrasive cleaners, and hydrogen peroxide-based systems are very effective and helpful to offer great cleaning and disinfection for long-term lens wear. So now, very exciting, we're going to talk about Hydra-PEG. So tangible Hydra-PEG is made from the lubricant polyethylene glycol. Tangible Hydra-PEG is a 90% water PEG-based polymer mixture that is permanently bonded to the surface of the contact lens. It's unique from plasma in that a distinct bulk layer of polymers encapsulates the lens. Hydra-PEG improves wettability, lubricity, surface water retention, and tear breakup time. And it also minimizes friction and deposition on lens surfaces. So this was recently FDA approved, and I've been fortunate to have experience with it for about a year now for my patients, and marketing is in early 2017. So I'm trying to contain my excitement here, but it's really worked so well for my patients, and we'll get to a few of them in a little bit. So we know that contact lenses, there have been many studies that demonstrate that contact lenses can disrupt the tear layer, causing tears to evaporate faster. This is well documented, well studied. In the tangible Hydra-PEG, what it does, it encapsulates the lens, so it's not just the surface of the lens, but I like to think of it like a blanket all the way around the lens, not just laying on top of it, that creates a mucin-like wetting surface. So tangible Hydra-PEG shields the lens from the ocular surface and the tear film, and it can be used for any type of contact lens. It could be used for hydrogel, silicone hydrogel, gas permeable, and hybrid lenses. So here are some benchtop test data, and tangible Hydra-PEG was shown to improve wettability, surface water retention, and lubricity on various lens materials. So wettability was quantified by measuring the advancing contact angle using the captive bubble technique. And the captive bubble method is where a bubble of air is injected beneath a solid and the surface which is located within the liquid. So this is instead of placing a drop on the solid, and that's how wettability was determined. So here you can see that, of course, the lower wetting angle is a better wetting surface. The Hydra-PEG is the pinkish compared to the control. And looking at the advancing contact angle for all three, gas permeable, silicone hydrogel, and hybrid lenses, the Hydra-PEG lenses had much improved wettability. The next slide looks at water retention, and the water breakup time was increased from less than 5 seconds to greater than 20 seconds in the gas permeable lenses that were treated with Hydra-PEG. So again, the pinkish is the Hydra-PEG, and here you could see much improved water retention for all three with the Hydra-PEG treated lenses. The next slide shows lubricity, and lubricity is the measure of the reduction in friction and or wear by a lubricant. Lubricity was measured on a scale of 1 to 6, with 6 being the most lubricious. And again, you can see the lenses, the pinkish, the Hydra-PEG lenses showed improved lubricity in the gas permeable, silicone hydrogel, and hybrid lenses. So it improved the lubricity in all lens types, the most pronounced improvement on the gas permeable lenses to the left. So you might be thinking, how is this actually done? How does this manufacturing process work? So the first step is really to activate the lens surface. So for cast molded lenses, a chemical activator is added to the lens monomer mix prior to molding. For lathe cut lenses, the lenses are exposed to a short plasma cycle. The lenses are then soaked in the tangible Hydra-PEG polymers. For cast molded lenses, tangible Hydra-PEG, you know what I'm talking about, polymers added to the blister packs during the autoclave process, and then for lathe cut lenses, they're soaked in the tangible Hydra-PEG during the extraction or hydration step. Hydra-PEG can be used for any patient. So, of course, when it first came out and was available to me, I chose it for my most difficult patients, so those patients that had significant wetting issues with their lenses, and there are no contraindications at all, and there's no need to change any lens parameters, no power changes or sagittal depth changes, no changes have to be made at all. The patients who really benefit the most are those experiencing dryness or discomfort associated with lens wear. So again, those patients with severe dry eye, the patients with graft versus host disease, Sjogren's syndrome, and those with exposure, also those with significant meibomian gland dysfunction as well. The patients who are known to be moderate to heavy depositors, and I love when patients come in and tell me, I deposit, and oftentimes they are correct, that they do deposit on their lens surface. Hydra-PEG's really a great option. And really any patients who experience fogging, especially during the day or towards the end of the day, that would like a cleaner surface, that in patients who don't want to remove their lens throughout the day and then reinsert them. So this came from Christine Sint, and it says subjects with moderate to heavy deposits reported clearer vision and less haze in the eye fitted with a tangible Hydra-PEG coated lens. So if you're wondering how you actually get Hydra-PEG, because I am so excited about it, all you need to do is contact any tangible Hydra-PEG certified lab. So the way to find your lab, you can look on the website tangiblescience.com, or you could just contact your local lab that you work with and ask if they have Hydra-PEG at this time. Then the next step is just to order the lenses with the prescription and design, request tangible Hydra-PEG coating, and the cost can vary, but again, just going to your lab and asking them and then proceeding from there. So it's incredibly exciting that laboratories now have tangible Hydra-PEG, and it's really just going to help our patients so much. It has helped them and will continue to help them. So when talking to our patients about Hydra-PEG, we want to educate them appropriately. So it is good to clean the lenses daily with a multi-purpose or peroxide-based cleaner, avoid tap water, avoid any abrasive cleaners or alcohol-based solutions. And Hydra-PEG may last permanently, but it may wear off with time. So especially those patients who deposit heavily or the patients with significant exposure, Hydra-PEG may wear off, and lenses can be retreated with Hydra-PEG as well. And again, no changes need to be made when ordering lenses at all, just requesting Hydra-PEG treatment. The tangible Hydra-PEG does result in a more slippery lens, and some patients might need a little training or retraining on how to handle the lens, but I found for my patients they've handled it pretty well. So they notice that the lens feels a little bit more slippery, but it hasn't been a problem with insertion or removal or handling at all. This is an image where you can see the clinical effects of Hydra-PEG. So the image on the left, you can see the deposits there on the lens surface. The image on the right, a much cleaner and clearer lens surface that has been treated with Hydra-PEG. So this was a study looking at Hydra-PEG as a solution to contact lens discomfort. So even with great contact lens materials, and I'm talking all contact lenses here, our contact lens dropout rate remains steady and really is much higher than it should be. And I think part of that really relates to treating the ocular surface, treating the eyelids and lashes, any signs of dry eye. But we do have really great technology in contact lenses, so both in soft lens technology, scleral lens technology, all contact lens technology has really improved. And I would like to see our dropout rates decreasing over time. So this study looked at 24 participants, and all reported symptoms of contact lens dryness and discomfort. So these patients were fit with AccuView Oasis lenses, and there were two groups. So one had Hydra-PEG treated lenses, and the other had untreated lenses. Each pair was worn daily for 7 days. They were disinfected nightly with hydrogen peroxide-based systems, and patient comfort and tear breakup time over the lens surface was analyzed using the Medmont topographer. So here you can see the tear breakup time over the surface of the lenses, and the top is the standard AccuView Oasis lens, non-treated, and then the bottom is the Hydra-PEG treated AccuView Oasis lens after 8 hours of wear. So here you can see this dramatically improved the tear breakup time, which can also help with contact lens wearing comfort in patients who have dryness and discomfort with silicone hydrogel lenses. So the comfort was rated after morning lens application, midday, and again at the end of the day. And the yellow you can see is the untreated OASIS compared with the green, which is the Hydra-PEG treated OASIS lenses. And looking at comfort, and the top is excellent comfort of a 10. Comfort was improved in all the initial, midday, and end of day evaluations of the lenses that were Hydra-PEG treated. So this is a patient of mine. We're going to go over a few patient cases here. So this is Martin, a 58-year-old Caucasian male who presented to me with severe dry eye. He reported worse vision in his left eye, and he was referred from an outside corneal specialist for contact lenses. He also had a history of corneal scarring in the left eye and a medical history significant for Sjogren's syndrome and also bone cancer. So he was using various topical treatments, including Restasis, autologous serum, artificial tears, preservative-free, at least 4 times a day without relief. And I can remember actually the day he came in, and similar to many patients that we see, he was just so symptomatic and very hopeful that there was something I could do to help improve his life. And, fortunately, with scleral lenses, he noticed much improvement. So we know that Sjogren's syndrome can affect the eyes, and we often see patients with dry eyes, and it also affects the whole body as well. So not only the eyes, the mouth, arthritis-like symptoms. Patients with Sjogren's often have brain fog, where they have trouble thinking. They have dryness all over their body, dry skin. And I encourage you that if you're treating someone with dry eye, and it could be any sort of dry eye, that you ask just the 2 simple questions: if they have dry mouth and if they have any arthritis. I found asking these 2 questions in my patients has really brought out a lot of autoimmune disease. And whether you order the testing yourself or work with someone else to order it, if you're at the point of treatment of the ocular surface where you think it needs beyond standard artificial tears, please ask if they have dry mouth or arthritis, and go a little deeper and see if they have any autoimmune disease. So it might be Sjogren's syndrome, it might be rheumatoid arthritis, it could be lupus, but patients have been diagnosed, and once they're diagnosed, they can also be treated, which can also improve their quality of life. So here you can see Martin, his examination, pretty good vision in that right eye of 20/20 -2, reduced vision in the left eye of 2150 with refraction, really no improvement to 2100 in the left eye, good vision in the right eye. You can appreciate with the pentacam his very irregular astigmatism in that left eye due to the corneal scar. So with slit lamp examination, Martin had pretty significant ocular rosacea. He had the typical findings of meibomian gland dysfunction and telangiectasia. He also had ptosis of the left upper lid. He had conjunctival staining and also had very significant corneal staining in both eyes. His tear breakup time was very reduced at 1 second in both eyes, and the posterior segment exam was quite normal. So one thing that I spoke with him about was, after looking at his eyes and his face, was to actually be worked up for systemic rosacea, which he did. I had him continue the Restasis, autologous serum, artificial tears, added in some ointment, added in omega-3 fatty acids, oral doxycycline, and eyelid hygiene. Now, one thing I like to tell my patients who have Sjogren's is about the Sjogren's Syndrome Foundation, which is a great resource. The foundation will also provide you with literature if you'd like to share that with your patients regarding dry eye and Sjogren's syndrome. And I find that my patients are just so appreciative that I actually know about Sjogren's syndrome and can provide them with extra resources. The Sjogren's Syndrome Foundation has group events like water tastings. They also have newsletters and raise money, so they have runs and walks and things like that. So it's really wonderful to share with our patients and to help them. So if you have a patient with Sjogren's, I encourage you to look out for the Sjogren's Syndrome Foundation. So I fit Martin with scleral lenses, and here you can see the parameters. He obtained great vision in both eyes, 20/20 in that left eye, which I was very pleased about. And he had an adequate central fit, and there was no peripheral blanching, but he did have surface debris on both lenses. What Martin said to me was that his lenses got dirty during the day. He needed to remove them 2 times a day, and he was compliant with hydrogen peroxide-based system. He was using sodium chloride along with Celluvisc in the bowl of his lens with insertion, and also was using Minicom Progent 1 to 2 times a week. So then his lenses were treated with Hydra-PEG, and this is his quote, so I'm going to read it to you. "The coating that you have had applied to my lenses works very well. It is a pronounced difference. I have not had to take them out to clean off debris during the day at all. They are quite slippery now, so must be careful when handling, but that's a minor issue. Thank you for suggesting this process. It has really helped." And it's been at least 6 months now, and he's still doing quite well. Lenses are in great shape, and it really has improved his vision, and he has not needed to take the lenses out during the day. So you might be wondering, how do we, prevent and manage this poor surface wettability? And since it's almost Halloween, I have a little treat for you. So here you can visualize the lens, and hopefully you can see that it's not wetting well, but it's a little video so you can appreciate it. So yes, that is a scleral lens that has color, but what I want you to get out of this is really the poor surface. This was a brand new lens and was not wetting. So to treat the surface of the lens, first we want to treat and manage ocular surface disease. And I could really go into this for about 2 hours, but I'm not going to do that. But I do want to prevent meibomian gland dropout. So here you can see the picture in the middle, the loss of meibomian glands. And the treatment and management, yes, it is chronic, but we want to educate our patients to use specific eyelid products to get rid of the debris and the bacteria and the biofilms around the eyelids and lashes. We want to, I'm a big fan of omega-3 fatty acids. Sometimes I'll talk to my patients about changing their diet, so eating more fruits and vegetables, less fried and fatty foods. Drinking water, of course, is very important. Taking breaks on devices, so looking away, blinking their eyes when on the computer or the cell phones. But really cleaning up those eyelids and lashes. If for whatever reason you look at someone's eyelids and you do not see any meibomian gland dysfunction, please just gently press on the lower lid and look for meibomian gland dysfunction, because non-obvious meibomian gland dysfunction is very prevalent, and oftentimes you'll see it even if you don't see it right away. We know that lipids and mucins are attracted to the hydrophobic gas permeable lens material, and sometimes scleral lenses are used to restore the ocular surface, and in these patients it's nice for the patients to actually wear the lenses for 3 to 6 months, and then after that time most of the mucus should be gone. It's also important to educate our patients regarding hand soaps that they're using. It is important, of course, for all patients to wash hands prior to handling contact lenses, but we want to make sure that our patients are using mild or basic hand soaps. Contact lens specific hand soaps are really nice. Acne treatment hand soaps are readily available for patients to purchase, but it is important that a patient is not using a hand soap that is oily or greasy, and because that can affect the front surface of the lens. It's also important to ask our patients about face and eye creams, making sure that they're applying these after the lenses are inserted. And of course, makeup is applied after lenses are inserted as well. So it's important not to use oil-based moisturizers on the eyelids, And we want to teach our patients not to apply makeup to the inside area of the eyelid margin, because that can definitely get on the surface of the lens. And constant follow-up and constant re-education is also important to make sure that the lens surface stays clean and that the cornea, of course, is healthy. So I always call this the year of eyelid hygiene products. There are many very good products out there, and if you're interested, here are some of them listed. This was in Optometric Management, an article that I wrote, and listed all the products. And what I would recommend is that you get familiar with your favorites, and it doesn't have to be one, it could be many of them, and have a few good options to recommend to your patients. So I found that this has been really helpful in order to clean the eyelids and lashes, help with meibomian gland dysfunction, and I like to start the treatment of the eyelids right when I first see the patient, so they could be a new patient to me, but prior to the scleral lens dispense visit is really helpful. I always talk to my patients about getting their eyelids prepped and ready for their lenses, which also helps with post-lens surface debris as well. It is important to use non-preserved or preservative-free saline for application. Lacquer Pure, introduced in January, is now the only FDA-approved solution to put in the bowl of the lens. Non-preserved sodium chloride inhalation solution can also be used. And I like to review really at every visit with my patients. It still continues to surprise me when my patients are wearing scleral lenses for 5 or 6 years and everything's great and I see them and everything's fine, and then something happens, they make a change and come in, and oftentimes it's their solutions, their products, something is different, and so then they come in with problems. One that I saw just the other day was using a soft multi-purpose solution to fill the bowl of the lens prior to insertion. I've learned over the years also to make sure my patients are disposing or recycling their saline after using it one time, not saving it, because of course that can cause a toxic reaction on the cornea. I really love peroxide-based solutions for cleaning lenses. The majority of my scleral lens patients are using peroxide, not all of them, but really many of them. Enzymatic cleaners are very beneficial, along with Metacom Progent. And for my patients that have more deposits, I alternate a daily gas-permeable lens cleaner with an extra strength or alcohol-based daily cleaner. And this has been helpful to keep the lens surface nice and clean. So here's another little video. Hopefully you can appreciate this image here of the poor wedding. And this is after Hydra-PEG, and you can appreciate it's a more clear image, but the nice clean surface, and how the tears are just going over the surface of the lens very beautifully there. It's crucial to clean the plungers, so we don't want any old ones or ones that are placed in a makeup bag or anything like that, because makeup can adhere to them, causing debris on the front surface. So the devices can be cleaned with alcohol and let dry, but alcohol can also compromise the hydrophilic lens surface, and it might be more beneficial to use a gas-permeable conditioning solution to just rub that on the surface to clean it and then let it dry. It's also, some people like to use the gas-permeable cleaner on the lens holder and then put the lens on prior to applying the lens as well to help with front surface debris. It is really important to replace devices often. I like to do it at least quarterly. A nice tip that I was introduced to recently was a practice that sold the plungers in bags of 10 or something like that, so patients have multiple plungers. It is important, and I recommend my patients have them everywhere. So the home, the office, the car, the gym, wherever they may be, of course in a clean container as well. We don't want them just thrown in the bottom of a bag or something like that. And informing our patients that they can get more online as well, but having them for our patients is really helpful and beneficial. Applying artificial tears throughout the day can also help to remove some front surface debris. Lenses could be polished as well, but that would remove the plasma surface. And then always determining the material, so looking at wettability versus the decay, and this may vary based on your patient type. So when there is debris on the surface of the lens, some patients like to use the squeegee technique, which is taking either the plunger or the edge of it with wet, so with solution, and sort of applying it in a circular motion, or using a wet or moistened cotton swab, again, just applying it in a circular motion on the surface of the lens. I find that some patients absolutely love this. They say, this is fantastic. I don't have to remove my lenses during the day. It's really easy. It's really convenient. And then I have other patients who think it's absolutely crazy that I'm even, talking about this, and they don't want to do that at all. So for those patients, they can just remove the lens, manually clean, rinse, and reinsert during the day. So really, it's based on the patient, and I discuss this with the patient and see which way they want to go. So this is a second patient case I had. So this is Peggy, a 56-year-old female who came in, and she had a history of corneal ectasia after LASIK. She is an excellent historian and told me she had GPC, long-standing. She had a history of eczema as well, and she did have a history of nudes and had retinal laser also. So she came to me already wearing scleral lenses, and I did some modifications and a refit. So she ended up with a reverse geometry design, a 16/6 diameter lens, but she did have a history of significant lens surface debris, and even the first time I saw her, she told me that she had a history, and she was absolutely right. Now, Peggy also had a history of recurrent discharge, and I just have all of her management strategies because she is incredibly compliant and was using all of these things, and she even had a little chart that she brought in to show me about what she did every single day, and she's probably one of my most compliant patients ever, so she has done a great job, and this is really for many years. Now, at the follow-up visit, this one time she came in and said that she had white discharge in both eyes, the right eye worse than the left eye. She denied being sick or having any allergies, and of course she was very compliant. So she did have conjunctivitis, but I did take a culture because I was interested in this discharge to see if it was actually an infection, and it was. So she did have a staph and strep infection, and I treated her with oral antibiotics, topical antibiotics, and topical antibiotic drops and ointment, and then she came back and her conjunctivitis was resolved, and of course very compliant, so that was just sort of interest. However, at that point in time, Hydra-PEG just became available to me, and so I said, let's try this, sent her lenses away to be Hydra-PEG'd, and this is her response. So my new lenses are absolutely amazing. My vision is crystal clear with the lenses. I can now wear them all day long without needing to clean them. My lenses do not fog up or blur during the day. And interesting, when I was preparing for this, I actually talked to her this week. She called me, and I asked how she was doing with her lenses, and she does have a backup pair of lenses. She feels more comfortable having two pairs that also have Hydra-PEG, and she of course cleans them prior to wearing them. She's doing great. So she now has two pairs of Hydra-PEG lenses, and her symptoms are much less than they were before. So I do want to thank you for your time and attention and open it up to any questions.
Thank you, Dr. Barnett. Our first question that we had was, how do you treat ocular surface disease?
Sure. Well, that's a great question. So for ocular surface disease, first I want to address the eyelids and lashes. So when I'm treating meibomian gland dysfunction or blepharitis, using a specific eyelid cleaner, using warm compresses. There are many commercially available warm compresses available now. Omega-3, specifically omega-3 6 fatty acids, and there are great products that are out there that are specifically studied and researched to help reduce inflammation in the eye. I might include a topical prescription eye drop to treat dry eye. It's exciting. We have 2 now. And also goggles, using moisturized goggles for my patients with Sjogren's syndrome, adding a humidifier at night, using lubricant ointment at night, and of course treating allergies as well. So it really depends on the patient, but I feel strongly that getting the eyelids and lashes and the surface in the best shape that we can prior to using contact lenses really, or scleral lenses, any type, definitely helps the whole lens wearing experience.
Okay. Our next question was, when tangible Hydra-PEG wears off, can lenses be retreated, or do patients need to purchase new lenses?
Right, so lenses can be retreated, which is a great advantage.
Okay. Can you share a list of recommended products, both hand soaps, makeup, and moisturizers?
Sure, so if the person has more interest, I'm happy to correspond with them as well. But some things that are really helpful are anything hypoallergenic like Cetaphil, cleanser and moisturizer. If you look at that list for eyelid cleaners, many of those companies also have different products to apply to the skin and the skin around the eyes. Makeup, some of those companies also have specific makeups. Blink, B-L-I-N-C mascara is really nice because it's like a plastic little sheets around the eyelashes that are easy to come off. Uieco, UIEECO, has a bunch of great products for the face and also the skin and the skin around the eyes that my patients with Sjogren's and ocular rosacea really benefits them. But really avoiding harsh chemicals. Mineral-based products are great for makeup as well. And of course, advising all of our patients to remove makeup, not only around the eyes, but of course on their face at night.
Okay, Dr. Barnett, another one is, if you have a patient using hydrogen peroxide solution for cleaning, do you ever have those patients soak their plungers instead, since they don't have a GP conditioner?
Oh, yeah, that's a great question. I typically don't. I think I've seen too many problems with hydrogen peroxide in the eye, and that's probably the reason. But I think for a compliance patient, yes, they could do that. That would be very reasonable.
Okay. How about this question's coming in, and it says, for a hydrogen peroxide, is it perfectly safe to use on the Hydra-PEG lenses?
Yes, hydrogen peroxide is safe and beneficial to use.
Okay. This next question I might be able to help out with, but it says, do you think there will be any type of warranty with the tangible Hydra-PEG?
I'll let you answer that, John.
Actually, each one of our laboratories and the individuals that you do business with will be creating their own policies and their own warranties, and it's important that you reach out to that company that you are doing business with and ask them specifically, number one, are you doing Hydra-PEG, and number two, what are your warnings surrounding that? Each laboratory is free to be able to set pricing, and it's important that you work with them directly, just like you would your consultants. Dr. Barnett, that concludes all the questions that we had coming that came in. I have to tell you, I thank you for such a spectacular webinar, and for our guests that tuned in with us, thank you also